Good afternoon, everyone. Welcome to the Tiang Seng Distinguished Lecture Series. My name is Tiang, and I will be your MC for today. Thank you very much for taking the time to join us online. Today's webinar is organized by the Yeo Boon Kim Mind Science Center with support from Mind the Gap 200. This webinar will be recorded and posted on Mind Science Center's YouTube channel. Towards the end, we will also be doing a Q&A with the speakers. Please click on the Q&A button located at the bottom of the screen to submit your questions. Should you need any assistance, please use the chat function and my colleagues will assist you. Without further ado, I will now pass the time to our Chairman, Emeritus Professor Kwa Heok. Prof. Kwa, please.
Thank you, Etienne. And welcome to the 11th Tiang Seng Distinguished Lecture Series. The theme is Women and Mental Health. And I must state very frankly to all of you that I'm expert in mental health, but I'm not an expert in women. There are three excellent speakers here who will talk about this issue, and they are Professor Helen Herrman from Australia, and two from Singapore, Professor Rathi Mahendran and Dr. Pearlene. Let me say something about the Tiang Seng Distinguished Lecture Series. It was from a donation by Mr. Tao Hing Tan in memory of his father. And in the past, we have speakers like Professor Norman Sartorius, the Director of Mental Health from Geneva, and also Professor Wang Ganggu, historian. We also have Professor Hong Hai, the Dean of the Business School, Jeremy Montero, the jazz musician. And for this webinar, we have three wonderful speakers, all on women issues. Someone have asked me also before we started this webinar, who is Tiang Seng? He was, like many of our forebears, a poor immigrant who came from the Chinese island of Hainan just before the war, and he worked as a steward in the British Merchant Navy. And he instilled in his children a sense of care, and empathy, and generosity. And I'm always impressed by the magnitude of the generosity of his son, Mr. Tao Hing Tan. And now let me say a few words of our keynote speaker, Professor Helen Herrman. Helen has been a wonderful friend and also very helpful in teaching programs here in Asia. She has special interest in youth and women's mental health and was a former president of the World Psychiatric Association. And she was also honored a national honor, the Order of Australia, and something which all Australians are very proud of, and we are very proud of her. So Helen, is all yours now.
Thank you very much, Professor Kwa, and it's my great honor and pleasure to be here. I greatly appreciate the invitation to join you and Professor Rathi, Professor Pearlene, and colleagues, and to send greetings to those watching online. So you've given me the important task of talking about women and mental health, navigating challenges and overcoming stigma. And I'm very pleased to begin. And I'm putting up to begin two photographs of young women that you may recognize. And I'll come back later to the relevance of that to our topic, although many of you might guess that, but let's come back to that. And through today, I'd like to, in the next few minutes, talk about mental health and mental ill health across genders. So looking at the dimensions of mental health status, the social determinants of mental health, which sit alongside the biologies that we all have, but then living with mental health and its consequences, looking specifically at mental health in women and girls and how to improve the mental health of women and girls in multi-level and various ways. So thinking of mental health and ill health, going right back to 1946, the World Health Organization, when it was established, declared that health is a state of complete physical, mental and social well-being, and not merely the absence of disease and infirmity. So that's a very clear statement that's inclusive of mental health, and also instructs us about mental health, that it's not merely the absence of mental ill health or disability. It's also the fact that we can be very healthy, as we may all be physically, and while none of us, or not many of us, are Olympic athletes, or not all of us remain completely physically fit, that we can still attain good levels of health, as we may in a similar way, if you like, analogous way with mental health. We can promote our mental health, and we do this individually, but ideally with the support of communities and social policies. And at the foundation of mental health is to do with how we are in ourselves, cognitively, and the way we think and remember, the way we relate to people in our families and beyond, and the sorts of learning or work that we're able to do. But at the key is social connection. And some, drawing on knowledges from my own country, the Indigenous, Aboriginal and Islander peoples in Australia, many of their beliefs about belonging to country and belonging to their communities is to do with social, emotional and spiritual well-being, and the deep roots in country, and disrupting the connections with country and with each other as a major precursor to mental health problems. And this is what we encounter around the world. And this is a slide adapted by the World Health Organization Western Pacific region in Manila from the Lancet Commission on Global Health in recent years. And it shows us how mental health is influenced by a range of protective and risk factors at each life stage. If we look here at childhood and even preconception through perinatal period and infancy, we see that adverse family circumstances down the bottom here, ranging from unwanted pregnancy to low stimulation, result in children experiencing early life stress that can really lead on to mental health problems in later life. We're more clear about this from research in the last 20 years. And here we have childhood and adolescence. They're critical stages of life for mental health and well-being. It's when young people develop skills in self-control and social interaction and learning. And negative experiences at home due to family conflict or to bullying at school, for example, have a damaging effect on development of these skills. And the socio-economic conditions in which children grow up can also have an impact on their choices and opportunities at that stage as well as later in life. And then mental health in adulthood is protected by meaningful work and healthy relationships, and substance abuse and unemployment puts that at risk. And in older age, if you can see that, it shows that mental health in older adults is protected by social security and support and put at risk through loneliness and chronic illness and financial insecurity. Well, coming now to the burden of mental ill health globally. This is a diagram or an illustration from the mental disorders collaboratives that was set up during the COVID-19 pandemic and published in the Lancet 3 years ago. And it shows with the women on the left, women and girls on the left-hand side of, as we look at this diagram, and men and boys on the right. But if we look at common mental disorders, by which we often mean anxiety and depression particularly, that women are more likely to experience these conditions or to report them. And the orange bits in the middle and the mauve parts are the additional components of those global burdens during the period of the COVID pandemic. As you'll see from this too, that it's the younger age groups that have the larger burden of these conditions. And this is very different from many of the other physical health conditions from which people suffer, where the burden of ill health is largely in older age groups, apart from one type of condition we'll come to. And here we have, again, the anxiety and depression, but also substance use disorders and how they're clustered in terms of their onset in the younger age groups. But also on the right, we have the conditions like dementia that rise in older people. And in all of these conditions, including in dementia, women are more likely to experience these than men for a number of reasons. So looking at gender differences in these disorders across the world, common mental disorders are more common in women than men across countries and cultures. Whereas if we look at the substance abuse and conduct disorders, these are more common in men. Women typically report more fatigue and pain or other somatic symptoms, along with depression and anxiety, than men do. But at the other end of life, or later in life, women have higher rates of dementia than men. This, of course, might be because women live longer, but also there may well be other factors as well. So what are the contributing factors that make women more likely to have mental ill health than men? That might be the exposure to gender-based violence, and we'll come back to that in a moment. The caregiver roles that women assume frequently for children and for their older relatives, and sometimes both at once, that are more predominantly in many societies borne by women. And the traditional gender roles that reduce autonomy for women and work outside the home, for example, opportunities for education and discrimination. It's diminishing in some parts of the world, but not to a large degree yet. Then there are hormonal and genetic differences and differences in the lifespan we've talked about. And culturally, men may not report emotional distress, and women are more likely to seek help. But overall, it's seen that perhaps these psychosocial, to some extent, the biological and cultural expressions are contributing to these differences. Now, looking up, I understand in Singapore you've had 2 national surveys of mental disorders, very authoritative pieces of work that have been seen with interest around the world. That in the survey conducted in 2010, women had 7% of women in the population aged 18 years and over were diagnosed with depression. For men, it was 4%. But that difference had narrowed by 2016 to 7% versus nearly 6%. And the reasons for this, I understand, are being discussed, and we may hear more about this, but it could have something to do with the narrowing of these traditional differences in gender roles. And the rating of poor mental health, this was using the General Health Questionnaire that looks at various parts of the experience of health and well-being, including fatigue and sense of comfort and pain. Women had 15% of women in the population, compared with 12% of men, were said to have poor mental health. This was an interesting observation in a recent publication that in the beginning of this decade, young women in pink and young men in blue had, as they advanced in each of these cubes from age groups up to 14, up to 20, and up to 25, there were slightly more boys and girls with mental disorders. There was increasing use of substance use disorders, particularly in boys, and increases in self-harm, particularly in young girls. Now, each of these, the numbers are small, but each of these, the commonality of these conditions is very different, ranging from an estimated 15% here in mental disorders and 3% in self-harm. So let's look at the social determinants of mental health and well-being. Well, mental health and psychosocial adversities go hand in hand. The young people who grow up in conditions of displacement, poverty, disaster, those who experience maltreatment are more likely to have depression, and these conditions will more likely produce depression as well. And there's a vicious cycle that's been pointed out over time, so that this began with the group. These insights really came to the fore with the group at Harvard University led by Professor Leon Eisenberg in the 1990s. But poverty, with its associations of low education and unemployment, is more likely to produce mental and behavioural disorders, and meaning people had less access to care and a more severe course as well, whereas that economic impact produced greater poverty, both individually and in society, and the clustering of these conditions amplifies them all as well. Moving on to living with ill health. So this poignant observation from John Steinbeck, if some of you remember his novel Travels with Charlie, written right back in the 1960s, a sad soul can kill you quicker, far quicker than a germ. This is referring to the greater mortality in depression that can come from the increased risks of suicide, but also we have increased risks of a number of common physical conditions such as heart disease, diabetes, and other causes of mortality, cancer, and so forth. Despite all of this, most people with depression, wherever they are in the world, have poor access to care or inadequate care. On the left-hand side, the two columns, the blue ones with high-income countries, the pink ones in low and middle-income countries, show that even in high-income countries, half of people with depression don't have access to care, and only 12% of these have access to what could be regarded as adequate care, with some combination of psychological and medication support as needed. And then we come to the question of stigma that's so much on all of our minds, that whatever stops people getting care, stigma is one reason. The shame felt by people, the discrimination experienced by people living with a mental health condition or with such a person in their own family. Now, this is quite odd in a way, because most of us know people living with mental ill health. Most families have someone in the wider part of the family with mental ill health, and yet the stigma remains important. And in recent years, people have started speaking out about this, and many campaigns around the world have worked on this. And the former Prime Minister of Norway said, notably, that stigma is the main problem regarding our efforts to improve the mental health situation in our families. He wants to contribute to combating stigma and tell his own story. So by people telling their stories, this is a powerful thing. And we come on to the importance too of mental health champions in communities. So we have public figures at one level and local champions who are helping to make this shift. So let's look at the mental health of women and girls. Overall, in all countries, women compared with men, they're more likely to be poor, more likely to experience violence and coercion, and less likely to have access to a number of things that are protective of mental health, like education, employment outside the home, and access to being able to make their own decisions or influence family and political decision-making. The other important thing for us to keep in mind is the unnerving prevalence of domestic violence or intimate partner violence. That around the World Health Organization has confirmed that around a third of women worldwide report recent physical or sexual violence from an intimate partner or someone else. And women affected by violence are at risk of mental and physical ill health to a greater degree than others. And of course, violence can also occur in communal conflicts, in wars, and in other behaviours like trafficking. But and of course, in community upheavals, as we see in many terrible situations around the world. Adverse childhood events have been studied to try and understand more about this situation. But the higher numbers of adverse childhood events, by which they mean maltreatment, or that is childhood sexual or physical violence, or neglect. In fact, neglect and psychological violence are seen as equally important. But more than half the people with significant emotional abuse in childhood develop major depression as adults. Of course, many don't, but that is a significant risk factor. Now, how to improve women's mental health? We look first at why have all around the world have we failed to address mental health needs equitably. So this is for women and men, but obviously has particular pertinence to women since they have more ill health. Well, first of all, we thought of mental health as a biomedical challenge, meaning that we think more about biology than society or family and community. We think about treatment rather than prevention, whereas in physical health with heart disease, for instance, we've gone to prevention. We think about specialist mental health care, yet very few people get access to that. And other conditions, we go to primary health care. And we think about clinical phenomena rather than how to recover. And this, so how do we deal with this? Well, first we look at what are the harmful social environments, as we've been talking about. Care is determined by needs, not necessarily by diagnosis. It's very different from a young girl in a refugee camp to a young girl in an affluent family in Singapore. Look at frontline workers, even in our wealthy countries. I always think about this in Australia, as you might in Singapore, that why do we rely so much on our psychiatrists and psychologists alone? We need them for care, but for expert care and advice. But in heart disease, we don't rely on psychologists on cardiologists rather, to keep us heart healthy. We need to use frontline workers, community workers, lay workers, and others. Embrace a rights-based perspective. It's very important that we consider human rights and find alternatives to coercive care that we've sometimes relied on in mental health, and place people with lived experience, like the Prime Minister of Norway, like those of us or those families and people who've experienced mental ill health in our own communities. Now, just as we think about the importance of treatment and prevention in reducing the burden of disorders, if we look at the age standardised burden of disability related to ischemic heart disease in this red line at the top, over 30 years from 1990 to 2020, the burden has declined, whereas the blue line representing the burden of depression has not changed at all. The change for ischemic heart disease relates to some degree to advances in care, but in larger part is due to public health measures, to encouraging people to stop smoking, to the campaigns you're familiar with, to exercise for your health, to eat healthy foods, avoid too much of the saturated fats and so forth. Whereas in depression, we've not been inclined to think that way. And yet we've seen how much the social and community factors affect mental health, particularly common mental health conditions. So the 4 policy actions are a whole of society approach for prevention and care, and I would add for promoting mental health. Redesign the architecture of care. We'll come back to that, to collaborative care approaches where we draw in all parts of the community to contribute. To invest more. We invest much less than we invest in cancer and heart disease in mental health, yet mental health burden is equivalent, and it is also affecting our young people more than our older people, or as much as our older people. And ensure accountability. How do we measure and account for that? So just to look quickly at the complementary approaches to the different approaches to preventing mental ill health and to some extent promoting mental health. First of all, on the top level, and these can be described as so-called ecological levels, the whole of society interventions to look at the structural determinants of health. Here we can look at gender equality and reducing discrimination against women or against or any other forms of discrimination such as racial discrimination. And we might look at economic determinants of health. So there could be introducing a minimum basic income or providing financial payments to those families and people with insufficient resources. Then looking at the different settings, what can be done to support people and mental health in families, schools, workplaces, neighbourhoods, and health services. In primary health services, finding people who are bereaved and providing them with support. In neighbourhoods, providing support to older people. In workplaces, providing more autonomy and more support in care. To schools, making sure there are skills and there's a whole of school support for respectful relationships and mental health, and families in the way we've discussed to reduce violence. And then there are a range of individual and family interventions across the life course, and we'll come back, for instance, to the perinatal period if there's time in a minute. Then looking at the care, this is the concept of collaborative care that's being embraced around the world for different genders and age groups, which irrespective of which the patients or the people with lived experience are at the centre, and they can enter the system at any stage. They can go to their primary health care, their schools, their families can seek help and go to primary health care, be referred to mental health specialist teams as needed, who might interact with employers, with schools, with families, drawing in lay counsellors as needed or community workers, and listening to families and people as we go forward. Then, in thinking particularly of how we support women with mental ill health, the gender-sensitive care is of prime importance. That begins with awareness and recognising that the proportion of women coming for mental health care who've experienced inequities and trauma in relationships, either family or community level violence. And this is particularly important for women with mental ill health, and the trauma is nonetheless rarely detected or acted on. Then we need to make sure that staff are educated and have a commitment. The role modelling is there for commitment to support for women who come seeking help. The needs for women for privacy and safety, and partnering, mirroring the relationships, the respectful relationships that support mental health, that the partnerships of the carers with women and their families have that quality. There is an online curriculum on responding to gender-based violence, can be found through the World Psychiatric Association. So improving women's mental health, we can think broadly about moving through interventions beyond the health sector, as well as cost-effective solutions to high-quality mental health care. Look at some of these policies and move through what we can. But if we look first at social policies and law, these are fundamental, but not necessarily sufficient. So we have international covenants for women, for the respect rights of women, the rights of children. They're not enough to change attitudes and practices. We often have laws about gender-based violence, but they're incompletely realised. And there is persisting discrimination that restricts women's social advancement in almost every country in the world, and sometimes very distinctly. And we need strategies to reduce the risk for women at all levels. There's a lot of talk about gender, but there's little accountability. So we need to think about a gender lens. When we do research studies, make sure that there are tables there for the effects on women and men, for example, and the same in social policy making. The United Nations has brought this into focus in partnership, particularly with UN Women, and taking on Commission on the Status of Women. And Respect Women is an initiative between the World Health Organization and UN Women that began just before COVID, but looking at relationships, empowerment, services, reducing poverty, making sure that schools, work and public places are women-friendly, preventing child and adolescent abuse. We just talked about the importance of that, and transforming attitudes, beliefs and norms. All of that big agenda, but one that we take forward. Now, coming back to Greta Thunberg and Malala Yousafzai, champions for climate and girls' education, respectively, who are the equivalents in our local communities for mental health that encourage people and communities to appreciate the value of mental health, the possibilities for improving it? I noticed that the Association for Women for Action and Research in Singapore was launched in 1985, and this is exactly what we're talking about. And you can see in the faces there and in the faces in this more recent photograph that the self-confidence in the young women and the women of all ages that is required for participation, and itself that confidence and participation support mental health. So there's a positive circle here. And this participation, working in communities, so global goals and local action, allows people in communities to tackle social and health goals and problems such as maternal and child health, violence. This is the way people organise in displaced communities, ideally, and also to tackle the isolation of the informal, the family and other informal caregivers for older people, for children with or without disabilities, for example. And this community participation is a central plank in community development, with community members acting on things important to them, led by them, with human rights and collective action at the middle, but drawing on expertise as required to strengthen the capacity of communities. And this adds to the self-confidence and the capacity to tackle the goals that we've just talked about. And one example in another region, if you like, but there's been studies that were published 20 years or more ago now in the Lancet and the British Medical Journal, community-based participatory action and its significant positive impact on infant as well as maternal mortality in rural parts of South Asia. Now, this is providing, for instance, 1/3 reduction in maternal mortality without any change in health care resources. This was done through getting together women's groups in local villages supported by trained local facilitators. So just look quickly at perinatal mental health. This is depression symptoms common in pregnant women and new mothers in all types of countries. Nowadays, we recognise this as common worldwide, and the consequences for the health and development of children, for the stunting of children in South Asia, for example, it's a common risk factor. And up to nearly 1 in 5 women in some countries can experience this. And we have 2 major strategies drawing on the multi-level concept I was discussing before: protecting women from human rights abuses at the broader level of insecurity and poverty, and preventing intimate partner violence, as well as working through early identification and treatment in primary and collaborative health care. And in that primary and collaborative health care, 2 strategies again: this participatory approach you just saw with the women sitting in a circle, but as well for the interventions by supported non-specialists, particularly the midwives and some of the primary care practitioners trained and supported by psychiatrists and mental health practitioners, psychologists and social workers in primary health care. And there are good examples of that around the world. So I realise we're coming to the end of the time, but just to say that professionals have an important role, but to strengthen the capacity of communities to respond to mental health, and being available as a source of expertise to support community engagement and teamwork, thinking in systems, and drawing in people in schools, in family welfare, urban planning, the digital world. For instance, training midwives and providing continuing support, allowing midwives to manage most of these problems of perinatal mental health themselves, but to be there as on call, and these mental health professionals being trained as trainers and in the skills for this type of practice. Very equivalent story in schools with teachers, that they manage most problems themselves. The professionals are trained and ready to support them. And this is how we invert the care pyramid, with the community and community workers and families are at the top, supported by primary health care and mental health professionals, with the leaders at each level being trained as trainers. So I just conclude to say that mental health of women and girls are threatened by violence and discrimination, but through participation and better mental health and development, we can make improvements with in partnership with mental health professionals. And the fundamental thing is to address public understanding and political will, and this drives the promotion and prevention at societal and individual levels. And access to humane and effective care in their own communities is the ideal and the trust that we seek. Thank you.
Thank you very much, Professor Helen Herrman. A very stimulating lecture. Helen, I learned a lot from you, for this talk. And there are also many researchers listening in. I'm sure there are many questions they can for their PhD projects and also the public policies. I must press on the second speaker, Professor Rathi Mahendran. Professor Mahendran is one of the most distinguished psychiatrists here in Singapore. She's also a very good teacher and also has a master's degree in medical education from the UK. But she's most well known for a study she did on community health and intergenerational study, CHI study, which is probably the only study in the world on aging, which involves not just psychiatrists, psychologists, and nurses, but also cardiologists, ENT, eye, orthopedic surgeons, dietitians, anthropologists, social workers, lawyers, economists. There's only one person in Singapore who can draw all these people together, this parade of specialists, and that's Professor Rathi Mahendran. So Rathi, are we ready to listen to your talk on your CHI study?
Prof. Kwa, but just a reminder, I think it was you who actually drew the whole team together. Yeah, so Prof. Helen as well, thank you so much for that overview that you provided earlier. I'm just going to focus on the community health and intergenerational study, the CHI study. I just want to highlight a bit before we move on. This study was done between 2018 and 2021. And then we also did a follow-up study, a longitudinal CHI study 3 years later. So with that background, and we also aimed to recruit 1,000 older adults, 60 years and above, for the CHI study. Unfortunately, COVID hit us, and it became a struggle towards the end to recruit numbers, but eventually we did manage to recruit 997 participants for the study. It was done mainly in the central and western region of Singapore, and our study site was at the Hannah Senior Activity Centre, run by the Presbyterian Community Services. But as COVID hit and we had difficulties recruiting people, originally we only had a 20-kilometer radius from that site where we would recruit people, but eventually because of COVID and recruitment difficulties, we actually extended that area another 10 kilometers. So this is the group that I'm going to be talking about. I'm only going to focus on some areas. I will give a brief overview of the demography. I will mention some medical conditions, talk about psychosocial variables and quality of life, and then go on to mentioning the cognitive changes and depressive and anxiety symptoms. So can we move on to the next slide and the next one, please? Okay, so this is an overview. We did not stratify recruitment by age or by gender, and so we ended up with more women in this particular study. Up to 65.5% were women, and they were both the men and women were in the young old age group. So slightly younger women, 67.68 plus or minus 5, and then 68.57 plus or minus 6 for the males. There were high levels of difference in terms of whether they were married and things like that. So 59.2% of our cohort, the women, were single, widowed, or divorced, and 8% of this amongst the males. Years of schooling was almost similar for both groups. And when you look at it, 12 plus or minus 4 years of schooling, then we're looking at a lot of people who definitely completed secondary education, had diplomas, degrees, some even postgraduate degrees in this cohort. Living arrangements, again, a stark difference between the women and the men. 21% of women were living alone as compared to 6% of males. Next slide, please. So, history of medical conditions. We found a high prevalence of the following medical conditions in females: arthritis, osteoporosis, thyroid problems, gastrointestinal problems. The darker blue on the slide shows the females, and the lighter blue, the males. In terms of hypertension, diabetes, there wasn't very significant difference, but there were some slight differences between the females and the males. Next one. Psychological variables. So we looked at various psychological variables and what impact they had on quality of life for our patients. What we found was that life satisfaction, positive attributes to aging, social connectedness, excuse me, and perceived social support were positively associated with quality of life, whereas anxiety, poor sleep quality, and negative attitudes to aging were negatively associated with quality of life. So when we looked at the breakdown for men and women here, you would see that females reported lower levels of social connectedness, satisfaction with areas of life, and a quality of life than the males. Next one. We also looked at levels of gratitude amongst the subjects in the study, and females reported experiencing higher levels of gratitude than males. Next slide. Here we looked at exposure to music, art, and exercise. And the reason for doing that was, as part of the CHI study also, we were planning to provide interventions and to study these interventions. And so that's why we needed some baseline data. And what we found was that the females in our cohort were more likely than males to have prior exposure to music activities and artwork. But when it came to exercise, they were spending fewer hours per week on exercise, and that was a significant difference. Next slide. So coming to cognitive and mood changes, right? Thank you. So we did very detailed neuropsychological assessments, and amongst the 997 individuals who were tested, 197 of them were found to have MCI or mild cognitive impairment. This works up to about 20%. Now, this compared to international studies in other countries, is on the high side. There are reports that it can be as high as 21% in some studies. And for ours, it was about 20%. And the females really were at higher risk of MCI than the males in our group. When we looked at MCI subtypes, so whether it was non-amnestic MCI or amnestic MCI, and we also looked at whether one single domain of their cognitive tests or multiple domains were affected. Again, we found that non-amnestic MCI was more often seen or noted amongst the females. Also, multi-domains of non-amnestic MCI was seen amongst the females. When it came to amnestic MCI, the males were slightly higher in the single domain, but in multiple domains, there was no significant difference. So not much difference at all. Equal numbers were seen. So this is in the first study, and I mentioned about a longitudinal follow-up study. So here we had 118 women with MCI, and then when we looked at them, next slide please. When we looked at them 3 years later, Remember, we were still in the COVID period. It was hard to get in touch with them and to bring them back to the center for testing and so on. Eventually, we only had 41 of that 118 who we managed, who agreed actually to come back for retesting 3 years later. Now, amongst these 41 females, none had converted to dementia. So that was interesting. Whereas we did see some conversion to dementia amongst the males. So none of these 41 had converted. About 36%, 37% remained with MCI. But interestingly, we had 63% who actually had reverted back to normal aging. So this aspect was studied by one member of the team, Assistant Professor Ted Ng, and they actually found that amongst those who had reverted to normal aging, they had been associated in higher levels of psychosocial activities. And we believe that could have had a benefit for these females. Next slide. So now looking at mood symptoms, we looked at depressive symptoms and anxiety symptoms. And in both presence of depressive symptoms on the GDS, Geriatric Depression Scale, and the past history of depression, we found that females were significantly higher than the males. And anxiety symptoms also were significantly higher amongst the females as compared to the males. Now, in the next slide, we will look at what happened. Next slide. 3 years later, when we went back to the cohort, again, remember this is a much smaller number this time, but nonetheless, more females still had more depressive symptoms than the males, but there was no statistical difference. In terms of anxiety, the females had higher anxiety scores, while males actually showed a decrease. So there was a change in the profile here. Similar in terms of depressive symptoms, not much difference between females and males, but when it came to anxiety levels were higher amongst the females now. So those are just the few slides I have to share with some of the findings. What important things that we can conclude? I think we did see differences among the women and the men in this study of 997 individuals. More medical problems in the females. More quality of life wasn't that great. Then they did have cognitive issues, which were higher, especially MCI in the females, but over a period of time, with introduction of interventions, they did benefit from it, and actually quite a sizable group of those with MCI, the women, had reverted to normal aging. And the last thing is about depression and anxiety. Depression sort of remained the same over time, but anxiety levels amongst the women did increase. So with that, I'll end my presentation.
Thank you very much, Professor Mahendran. There is so much more data in the CHI study, which you will tell you in other webinars, I'm sure, Rathi. But this important point is that those who are able to express their gratitude are more thankful, seem to have better mental health, and it's more among the women, isn't it?
Yes.
Right. So you see that Professor Helen Herrman spoke about the global picture about mental health around the world, and then Professor Mahendran spoke about Singapore and the regional. Now we go on to the individual, and I've asked Dr. Pearlene Ng to talk about resilience on individual person. Dr. Ng is a clinical psychologist trained at the Institute of Psychiatry, King's College London, and she's the principal coordinator for the curriculum here in Singapore, the master's program on mental health, clinical mental health, and psychotherapy. So Pearlene, it's all yours now.
Thank you so much, Prof. Kwa. And thanks, Prof. Helen and Prof. Rathi for sharing such insightful sharings. So as Prof. Kwa mentioned, my section today really be from an individual perspective, and I draw references from a lot of the clients, female clients that I work with, and also the female peers and family members that I have. So, as my esteemed colleagues have earlier shared, research has shown that women are more susceptible to poorer mental health. So I just want to share some of the reasons that I've seen anecdotally amongst my clients and peers and family members around that may be factors for why women are more susceptible to poorer mental health in Singapore, in our local context. So the first is caregiver role, as Professor Helen has already mentioned. Women in Singapore continue to shoulder a disproportionate amount of caregiving responsibilities for their children and elderly family members. Research have shown that about 60% of caregivers are women, and this role often comes with emotional, physical, and financial strain as it limits the time they have to care for their own needs. This then requires them to also play a balancing act between their needs and the needs of their family members. Many women find that they have to juggle multiple roles where they balance their careers, caregiving, and household duties, which can lead to chronic stress and burnout. This reminds me of a situation or an experience my colleague shared recently with me when he was on a Zoom call with a student on our master's program, and the student, while trying to have a Zoom discussion with him over a research project, was actually entertaining her 2-month-old newborn with finger puppets on her fingers while trying to multitask. So this shows the balancing act a woman has to play oftentimes. And also due to societal expectation in Singapore, women still have to take on many traditional gender roles as a mother and caregiver amongst, being a career working woman, etc. The need to juggle multiple roles often leave women with little time to prioritize their own mental health. And this lack of self-care can increase vulnerability to anxiety, depression, and other mental health issues. So with so many things on their plate, women also naturally find it harder to seek treatment. Even when they do find time to seek treatment, they are often faced with stigma from others and themselves. So while stigma towards mental health can be experienced by everyone, women face a disproportionate amount of stigma. So if I want you to kind of think about our everyday language that we use, right? When we refer to people with mental health issues, or when we refer to women with mental health issues, we have local language or colloquial language, right, describing them as, xiao zha bo, right? But we don't have language for men. So this shows the amount of, discrimination that women tend to have as compared to males. As a society, we are also less forgiving towards women. And the other aspect is that women also experience self-stigma. So I have a lot of clients who mention, even when they come to see me for treatment, they say that, I feel I'm taking up space and I don't deserve your time and other people may need it more. So such beliefs may actually prevent them from seeking help, hence leading to poorer mental health. Okay, so what can women do to improve our mental health? As I prepare for this sharing and reflect on the different experiences my clients have shared, I thought of a framework called SHE, quite aptly, and S stands for self-care, setting healthy boundaries, and empowering ourselves. So the first thing we can do to improve our mental well-being is doing self-care. Self-care means taking care of yourself and addressing your needs. We all know self-care is important as it boosts overall health, mental well-being, and confidence. In my interaction with women clients, peers, friends, and family, they often tell me, I don't feel like I deserve self-care. For example, when they say that if they have a bit more time or a bit more money, they would rather spend it on their children or their spouse or their family. However, this quote reminds us of the importance of self-care. Norm Kelly says you can't pour from an empty cup. You have to take care of yourself first. So if we don't take care of ourselves, nobody would, right? And how would we have the sustenance to continue taking care of our loved ones? Let me ask you a question to kind of sort of reflect, right? When was the last time you actually took care of yourself? When was the last time you bought something nice for yourself, something that you like, or you did something nice for yourself? Right? So how can we ensure that we kind of remind ourselves to do self-care. One way is to kind of do a daily self-check-in by asking ourselves, what do I need today? Do I need rest? Or maybe do I need a bit more time for myself? Right? A common misconception about self-care is that it has to be expensive or time-consuming, right? For example, people think that, oh, self-care has to be a grand gesture like going for facials or massages. And certainly that would work. I know I would love to do that every day if I could. But actually, self-care doesn't have to be expensive or time-consuming. Years of working with clients have taught me some great examples of simple and inexpensive ways of showing yourself some love, such as maybe even allowing yourself to use the expensive hand soap or lotion once in a while, or even every day, making yourself a nice cup of tea, or even allowing yourself to sleep in an extra 10 to 15 minutes in the morning. Though these actions may seem simple, the intention and the message behind these actions tells us that we are worth it and we can care for ourselves. Let me give you a bit more examples of self-care. So it may include practice meditation or mindfulness, reaching out to your friends, either texting them, video chatting, going out for meals, or even planning a girls' trip. Working out and finding ways to stay active, so taking care of your body. Eating well-balanced meals, of course, with the occasional treats like chocolates, cookies, cakes, whatever makes you happy. Setting and following times for work and rest, setting boundaries, and getting sufficient rest, at least 6 to 8 hours a day to make sure you get the sleep you need. So hopefully you may like some of these ideas and some of these may speak to you. I encourage you to set an intention today to do one of these to give yourself some love. So on the topic of setting boundaries, another thing we can do to improve our mental well-being is setting healthy boundaries. Many times, women that I work with or female friends and families often tell me they have difficulty saying no, or they don't know how to say no. They are afraid to reject people and therefore are afraid of people rejecting them because of this rejection, right? So Brené Brown actually reminds us that setting boundaries is having the courage to love ourselves when we risk disappointing others. So don't be afraid of saying no. It's important to know our limits and to prioritize what we can do and delegate what we can't. Don't be afraid of asking for help. Don't be afraid of delegating and prioritizing ourselves. We also shouldn't feel bad or apologize for needing space, for occupying space for ourselves and occupying space when it matters. Consider setting the following boundaries if things get a bit too much for you. So there are different types of boundaries. I'll cover 3. Right? The first is setting physical boundaries, and these relate to personal space, touch, and physical safety. Examples of physical boundaries may include having designated areas where you prefer to be alone, like your bedroom, wearing headphones, or even using other signals to indicate you are busy and prefer not to be disturbed, or simply clearly communicating to others that you need more distance when you feel overwhelmed or uncomfortable. You can also set emotional boundaries. These protect your emotional well-being and help you separate your feelings from others. Examples include not taking responsibility for others' emotions. Right? So if your spouse or your friend, family is upset, angry, disappointed, you don't have to take the responsibility. You remind yourself that you're not responsible for making them happy or managing their emotions. You can also set time boundaries, and this involves protecting your time and energy, which allows you to prioritize your tasks and activities. So when you're able to set boundaries, you're then able to allocate time to yourself to look after yourself and therefore improve your own mental well-being. Right? The last part of the SHE, which is empower. So what we can do as women is to improve our mental well-being by empowering ourselves. Empowerment begins with the permission to allow ourselves to take up space, to speak, and to matter. So we can utilize all the techniques or coping strategies in this world to help us manage our emotions. But as long as we do not feel empowered, we will fall back into the same patterns or habits in due time. For example, we might have people-pleasing habits that will hold us back. So when we feel empowered, we're able to better let go of habits that hold us back. It also allows us to find and use our voice, to say what we want and ask for help. Being empowered also means being able to gain control over our emotions by learning and utilizing relaxation techniques and emotion regulation techniques to manage our emotions better. Right. And lastly, when we are empowered, we want to be able to celebrate our strengths. Don't forget who we are and don't lose ourselves amidst all the chaos, in the world that you might find yourself in. So I really hope that we'll be able to empower yourself to be the best version of yourself. So with that, I come to the end of my sharing. I hope that you will take away the 3 key points for improving our self-care, SHE, so self-care, setting healthy boundaries, and empowering ourselves. Thank you.
Thank you, Pearlene. So listening to Pearlene, I'm just wondering whether schools in Singapore or in Asia, they can have a special session in schools on mental health, But make sure it's not for exams. Just to teach them, give extra. I think that's very, very important because we often tell them things and it doesn't percolate down to the school level.
Certainly.
In Australia, Professor Helen Herrman, is there anything on the mental health in the school curriculum?
Well, we have, I think there's some of it in the curriculum, yes, but there's also a program on promoting mental health in schools that's quite widespread, one for primary and one for secondary schools, government organised. So promoting the idea that schools have respectful relationships and looking at relationships between teachers and students and preventing bullying and understanding that better mental health means better education. So that is available to look at. And I agree with you, it's such an important thrust.
So thank you. There are so many questions. There's one question by a lady called BB about trauma in childhood, and its aftermath, So every night or every evening when you watch on prime time television, you watch the catastrophe or the tragedy at Gaza. You wonder about what happened to the children who are seeing all this disasters going on, and what will affect their mental health, and how many of them will be like the Afghan girl called Miss Malala, who rise above all this, and become a beacon of hope, So once again, for the 3 speakers, are there any programs, that the counselors who are listening in can use for children with early trauma, Helen or Rathi or Pearlene?
Well, I was waiting for Pearlene to come in because of her beautiful talk.
Pearlene, anything that you can share with other counselors listening in? I know it's the one in the Palestine is utter tragedy. It's so and it's very sad to see what's happening around, and you wonder what happened to them when they grow old. They leave a scar in their mind. Pearlene, anything you can a program you think they can look up to? Where's Professor Mahendran? He's just gone off for a while.
Yes. So this is relating to women experiencing trauma.
Young people, young children, the trauma like war or tsunami, that kind of thing.
Yeah, I think definitely that there are quite a lot of things that can be done to support young children. For example, any professional care, especially in war zones, there are trained professionals to support in terms of providing psychological first aid. But I think as what Professor Helen has mentioned, a lot of it starts with the family and the community and the systems that they are in. So professional care is one aspect, right? But I think it's also tapping on the strength of the systems and the communities to support these children. And so we cannot take away the adversity that they experience, but as they are growing up in their adult age or adolescent age, there are definitely some protective factors that we can work on to provide them with better support, so that can cushion some of the impact of the trauma or the adversity that they face in their early childhood.
Yes, I agree that that's in a sense coming back to the schools and to supporting normality. If the children are in those circumstances, re-establishing education, or to supporting the parents to provide normality, if you like, for their young children, and providing support to families to talk with the children or comfort them and and manage their own conflicts without the children witnessing as much that them being in conflict. And managing substance abuse, which often goes with these situations too.
Another question is about women live longer than men, being the stronger of the gender, but there are a lot of women who are now living alone, and loneliness is now a higher risk of depression. So we wonder whether in other parts of the world, Helen, besides Australia, are there any programs for people, elderly people living alone? Because many, even in Singapore, many the parents are here. I look up. I got a professor, a doctor here, who told me that his wife is ill, and I know the family. I asked him, where are the children? Oh, they're all in Australia now. You know,
Nice.
so they're all living alone, and they're looking for any program you think that we can help people.
Yeah, look, I think this is there are now, as we know, ministries for loneliness in some countries, including the UK, but certainly there's a focus on the importance of support for elderly people across the world in many countries. And that can be manifest in providing community programs. We have neighbourhood houses and programs of support. There's some programs of providing free transport for elderly people so that they can visit others, and different group activities, volunteering and so forth. But also the reaching out to people who don't come to those things. And that's where primary health care can come in, to be aware of those who've been bereaved, those who are living alone, and those who are experiencing other life difficulties, including ill health. And the highest rates of suicide, as we know, and you would know, Professor Quah, are in elderly men with ill health, particularly those living alone.
Rathi, anything in Singapore you're going to share with your neighbors in ASEAN countries about what kind of program the community or kind of public policy we have for people living alone?
So I think, the Ministry of Health has been working with the different agencies, social agencies and health agencies, actually to try and enhance support for elderly living in the community. So now they do have community nurses, and where they have identified individuals who are older adults who are living alone, have very little support, for example. So they do try as far as possible to do home visits, and particularly if they have medical conditions, the hospitals will definitely engage the community nurses to pay particular attention to this group. And I think also on the social level too, because we live in our HDB blocks now, there's greater awareness of these individuals who are living alone, and they're trying to get neighbors also to step in to help. So that's where the block, I think it's a block committee or something like that, where they will identify these individuals and help. So I think it is going on at different levels. It becomes a bigger problem as the individuals become older and frail and can't leave the house. I think that's the biggest risk.
Yeah.
And we do from time to time hear about elderly who have passed on, and then no one knows about it until a few days later. Unfortunate things still do happen, but I think we are very aware of the problem on the ground, and we are trying to make some changes. Yeah.
Thank you very much. Somebody called Chloe mentioned about the NHS being very stretched. I think she must be back from UK. But mental health in Asia has always been the Cinderella of the health service, and always very stretched. So I don't know how much time Pearlene has for her patient, but in many other countries, you probably just about 15 minutes, and how they're going to find out, explore, and look into the early life histories. And what do you do, Pearlene, then, when you are seeing just 15 minutes to see a patient? You have 50 patients waiting for you in the morning,
Which we, as well, I think one of the advantage of being a clinical psychologist in when I was in the NHS versus and also locally is that we have a standard duration to see our clients. So for example, we block out maybe 50 minutes to an hour to see our clients. However, that results in a longer waiting time. So even though we can see our clients for a longer time, then the repercussion is that, you know, there are less slots, there's less appointments available, and therefore other people would take a longer time to get another appointment or to see a psychologist. So there's no perfect solution in this instance. I think it talks more about systemic demands and systemic changes that have to happen. For example, increasing the number of mental health professionals that we have, going beyond maybe psychologists, psychiatrists in terms of providing support for mental health issues, right? And think about it quite creatively as well as how we can meet the demand.
Right. I work at the NHS in 1977, almost 50 over years ago, At that time, when I go to the clinic, I only have 2 patients waiting for me, Then when I came to work in Singapore, the first day at the clinic, I had 33 waiting for me. But people like Professor Mahendran, she sees about 40 or even 50 patients, I don't know exactly how they do it. But these are some of the issues, Professor Herrman, that the World Health should know, or the WPA, that although sometimes we draw a wonderful curriculum or program for them, at the clinic level or the shop floor level, it's very challenging.
Absolutely, and we admire those who do this. But this is where I think the principles of collaborative care come in, that as mental health professionals, there'll never be enough. And even Singapore and Australia are relatively affluent countries in the world, and yet we have many shortages, particularly in Australia and in remote areas and rural areas. But what the sorts of things that we can do are, and people are turning to peer workers, to those who've been through this experience as adjunctive helpers, and can do a magnificent job, and to other types of community workers. And in addition, there are the digital initiatives, particularly those that continue, that can provide care between visits or continue care beyond an initial episode of treatment. And these are becoming much more sophisticated and individualized as we go forward.
Thank you very much. So there are many things that can be done, and I'm glad that here in Singapore it is on the radar screen of the government now, mental health, and they're putting some effort into it. And as Professor Mahendran said, we should be grateful and be thankful. When I first came to work here in Singapore almost 40 years ago, that's the situation. There was a Cinderella, but now we're moving slightly up. There are many more questions, so you sent to me yesterday, in fact. So I thought I'll put up some slides to show you some. People ask, what are you all doing? Instead of telling us the problems, the prevalence of depression and all, are there any program to prevent? So let's be going upstream to do something about it. So we've done some studies. I'll quickly run through before we close. I'll get Jia to help me out with this. This is a study I did with Professor Mahendran, and there are many other people involved. It's called the Jurong Aging Study for the Prevention of Depression and Dementia. Over 1,000 people around this part of Singapore, the western part of Singapore, and it was stationed focused at a shopping mall. And this idea of a research team in a shopping mall was borrowed from a friend of Professor Helen Herrman. Professor Patrick McGorry came to Singapore 25 years ago. I was then the CEO of IMH, and he told me that he set up a clinic at a shopping mall in Melbourne for early psychosis. So I thought that's a wonderful idea, and we are very glad that a friend of us gave us space at a Jurong Point shopping mall. The rental is $7,000 per month, and he gave us rent-free for 10 years, and even gave us $1 million to help our research. So this study is about 1,000 people, 80% are women, and mainly Chinese. Next slide, please. Yeah, hold on. But yeah, so it's a study on prevention, and there's also a paper published in the Lancet. So we realized from our memory clinic in NUH here that dementia, depression are linked to two diseases. Diabetes and hypertension. And also, we in the health talks, we talk to them about diet, falls prevention, and then we divide them into four modalities of Tai Chi, mindfulness, music, and art. And this is a very meticulous, rigorous research with brain scans, immunology, neuropsych assessment, and it's a wonderful study. And we follow them up for 5 years. Next slide. And in 5 years, this is the outcome. The depression rate before was about 8 or 9%. It was half with this intervention. And the dementia rate for the government is about 10%, but here is only 3% of the intervention. It has been discussed at the World Congress a couple of years ago, and also a book been published. And we thought that maybe that's the end of the story. But someone suggested that we should, in a way, translate the research to the community, not just in one center, can we extend to many other communities? Next slide, please. And we show that now there are more than 10 centers in Singapore with this program called the HUL Everyday Program. Now, you look at that program, most of the volunteers who help us out are in fact women. And most of the people attending all these programs are also women. And as Professor Mahendran mentioned also about the program in the Chi study, a different part of Singapore, also the women, and maybe it's the reason why their conversion. Remember what she mentioned about the conversion from the MCI to normality was more in women than in men because the women were more involved. There are 3 centers in the world doing dementia prevention. Here in Singapore, the other in Finland, and one more in Paris. And the study in Finland, they did for 2 years and did an analysis. Here in Singapore, we've done 5 years. But in other 2 centers, they have no volunteers. They pay all their so-called trainers. Here in Singapore, they're all volunteers, and we are very grateful to all these people who volunteer the time to go to the community, and you are trained first before they move on to the community. Now, we also realized that many of them, during the pandemic, they were not able to leave the house. And we thought maybe we should continue the program, and we suggested digital mental health. Next one. And so what we did was using a smartphone and you use it mainly to study amongst the Malays. Because in all the studies in Singapore, whenever I present to the WPA, the World Health, they'll tell me that all your data about Chinese. So this is a study among the Malays and how it affects the mental health, all of them. It will be published in a book called Aging and Dignity, and with Dignity. And so we told them every week you allow them, send them a message on diabetes control or diet or exercise or something on art therapy. And whether after 2 or 3 months, we can ask them, would they like to volunteer in the mosque? So besides just giving, can they give us something back? So you see that they've been very, very helpful. And when the pandemic was over, they gathered together in the picture in the public parks and the forests together. And I joined them a couple of times, and they're wonderful. They'll come out with people volunteer to make cakes and nasi goreng, various things. And now it's not just once a week. In fact, every morning they'll send each other a message, good morning or salam alaikum, And it's wonderful because they built the community together. It's the social connectivity that we are very concerned with. We also know that many people in the studies do not have the full-blown picture of depression, or anxiety. And they have subclinical depression anxiety. And this is more often during the pandemic, and people are staying in, become very anxious and mildly depressed. But then the issue is, if you don't do anything to all these people with subclinical depression and anxiety, they may drift into depression. And to get an appointment to see Professor Mahendran or Dr. Pearlene in Singapore is a long time. And I know in the public hospitals, about 4 to 6 months to get a referral to see a psychiatrist. Professor Mahendran, private clinic, maybe about 3 or 4 weeks, Professor Herrman, I just rang up my nephew, who's a psychiatrist in Newcastle, north of Sydney, and I asked him, when do you see a new patient? waiting time. He told me it's 1 year. 1 year to see. So what we have done in Singapore is we try and train some of the seniors, the elderly people, the retired teachers, nurses, whether we can teach them some skills on psychological first aid. And then they can provide some psychological first aid. And if the case is not well, then they know the people in the hospital who to refer to. But they provide the first aid to prevent them from dipping into severe depression. Next slide, please. So this is the psychological first aid. It is based on a training program we call Brief Integrative Personal Therapy. And this is the work of 5 people, Professor Cheong Pak Yuan, Goligan, Vicinto, Prof. Woon, and myself. We use it more for the GPs, and it evolves from established psychotherapies, like elements of cognitive behavioral therapy, elements of focal therapy, and the techniques are, what are techniques appropriate for the person? Not everybody needs CBT, and it's very difficult sometimes. And what are the cultural contexts? Because some patients will prefer mindfulness meditation as a way. And in all these therapies, we emphasize on healthy lifestyle, which is very, very important. During my training in psychiatry in 1977 in UK, my first consultant was a woman psychiatrist who's a psychoanalyst, and she taught me about psychoanalysis. And then a year later, Professor Aaron Beck came from Philadelphia to teach us cognitive therapy. And in psychoanalysis and in CBT, no one talked to us about healthy lifestyle. To them, you do your own thing. I'm just going to teach you CBT, and the other lady will say, I'll talk to you about psychoanalysis, So, but here in Asia, people ask you, what food can I eat? What should I exercise? So healthy lifestyle is very, very important. And now this, the paper published, is hot from the press. It's just been released, I think, last week. The lead author is Professor Shifali, who is the Vice Dean of Medicine, a nurse by profession. And it's an excellent paper in the Journal of Medical Internet Research. And I think it will move very fast because many people are using it. I was at a Royal College meeting a couple of years ago. There's some discussion of brief integrative personal therapy, using the psychoanalysis or psychoanalytic therapy or even CBT by itself may not be very appropriate for most people. But these are all peer volunteers. You see, Shifali was training the people who are seniors and hoping they'll provide that kind of care. So we are hoping that this kind of therapies will help and to help out the community. As I think Professor Helen Herrman mentioned also, they're thinking about using volunteers as non-professional, train them, provide psychological first aid. Now, I know time is catching up now, and I have to once again thank all the speakers, Professor Helen Herrman from Melbourne, Professor Rathi Mahendran from Singapore here, Dr. Pearlene Ng, and I must also not forget our benefactor who is listening in, Mr. Tao Heng Tan, and also the webinar today, although it's just 1.5 hours, it's taken 1.5 months to get it organized, And the Mind Science Center, there are more women than men. 75 years ago, Chairman Mao told the world, women hold the other half of the sky. But the women here will tell you that Mao is wrong.